I have so many fond memories of the Mid-North and Melrose. We've had a great trip here. I used to be a medical student in Clare, and in fact the very reason I became a urologist is because I sat in on Kim Peasy's clinic in Clare. Some of you might know him, he's an old Clare boy, and he had 3 men come in that morning with prostate issues. And I was sold. I'm like, this is the best job in the world. So here I am talking to you guys, and I have the great pleasure of continuing to work with Kim in public and private practice now. And I guess just to add on to what Alice was saying, it really brought home to me, my dad had bowel cancer when he was 46. So I was a medical student and we'd gone on a holiday, and I remember on this holiday he said to me, he said, Soph, I'm farting more, is that normal? And I thought, we're on a holiday, we're in Greece, God knows what you're drinking, that's normal. And we got home and he had a show of blood in his stool, and he went to his doctor and he was diagnosed with bowel cancer and had surgery and radiotherapy and chemotherapy all really quickly. And he's still with us now. It's almost 20 years and he's doing really well. So it's well worth just anything you're worried about. You've got Alice here. It's easy to get a checkup. So is there a clicker? Or you've just been pressing? Yep. So tonight I'm going to talk about prostate cancer, and I'm going to talk about incontinence, and plenty of time to ask any questions. It's a really interesting topic. Obviously I've dedicated my life to it. So what is the prostate? Everyone always says, what is this thing? And was it always there? Why is it giving me trouble now? So the prostate was always there. You were born with it. And when you're born, it's really small. It's kind of the size of a walnut, and then it grows. And it's a natural part of aging that this gland gets bigger as you get older. So it kind of stays a normal size until you're about 50. And then once you turn 50, all that testosterone in your body makes it grow bigger, and it starts causing you problems. It causes either cancer, or it gets really big and it might cause a blockage and you can't pee very well. So it's a natural part of aging, unfortunately. And what's its job? The main job of the prostate gland is it's kind of the epicenter of your downstairs. So it creates and it makes all of that fluid that's in your ejaculate, and it blends that with the semen, and that's what it does. So it's really important in terms of reproduction. And then, once you turn 50, 60, it just causes you trouble. So we're very grateful to it, but it's a bit of a naughty organ. So prostate cancer, the main way we diagnose it is actually from a blood test. So men will go and get a blood test, and you should get them from when you're about 50. If you've got a family history, so if someone in your family's had prostate cancer, you should be tested from about 45. And it's once every 2 years. So your GP just adds it onto a normal blood test. Now, important to mention, we're in Melrose. So the sorts of things that make your PSA go up normally is infection, so urine infections, cycling. So if you like cycling, just hold off for a few days before your blood test. Any sort of sexual activity will actually cause it to rise. So again, you've got to hold off a few days before your blood test. But that's the main way. The other thing is, a man might come to us and say, look, I can't pee very well, it's kind of been changing, I'm up all night. And that's usually not cancer, but occasionally it will be cancer. So the prostate getting bigger because of cancer. And very rarely, a guy might come to us or see their GP and say, I've got pain in my shoulders, pain in my hips. They get an X-ray, it's not a fracture, it might look like cancer. This is rare these days, it's really rare, but it might be that we don't diagnose it until it's spread outside of the prostate. So they're just the things to keep in mind, but the most common is the blood test. How do we investigate it? The GPs do the blood test, they send you to a urologist. So you would see Kim if you were seeing someone in Clare. There's a urologist who goes to Port Pirie, Port Augusta and to Whyalla. They would send you along, you'd get an MRI scan, and then we do prostate biopsies. And I think each and every one of those sites we can do the prostate biopsies. Now you have a general anaesthetic, you're out to it, you're not aware. The MRI scan, you go into a tunnel, I've got a picture of that. That's the MRI scan. I think the closest one here is in Elizabeth. And you get that scan done. It'll take about half a day by the time you get there, sort out the scan, come home. And that scan gives us these beautiful pictures that really show us if there's an area in the prostate that looks like it might have cancer. So when we do the biopsies, we can take biopsies of these shadows. So there's this sort of shadow here that corresponds with the black point there. And we'd say, okay, we'll take some biopsies from that area, but then also we take biopsies from other parts of the prostate. So the procedure takes about 15 minutes. You'll have some blood in your stool and in your pee for a couple of days. You'll have blood in your semen for up to 3 months. That's normal, because remember what the prostate does? It creates all the fluid, so it's going to keep flushing it out. But that will all settle. So prostate cancer, like bowel cancer, when you find it early, although it's a bit of a bother that you might need to have treatment, it's actually life-saving. Like, we can cure it. And most men in Australia, it'll be caught at a point at which it can be cured. So 95% of men will have a cure at the time that they're diagnosed. If you've got low-risk disease, we now know that we actually shouldn't touch you. No surgery, no radiotherapy, nothing. You should just have a blood test every 6 months or so, maybe an MRI scan every couple of years, because of those men with low-risk disease, like 60% of them will never need treatment in their lives. It will never grow, it will never change, it'll just stay like that. So in those men, we don't touch them. 40% of them, it might grow and change and they need treatment, but 60%, nothing. So a very hands-off approach for those men. There's an intermediate risk group. Most men are in that intermediate risk group, and those are the men who should have treatment if they're going to live another 10 years. So for us, our screening cuts off at 75, like the bowel cancer screening, for that reason. Because if you're 85 and you've got intermediate risk prostate cancer, well, we should have never done the test. We should have never done the biopsy. You should never know about it. It's not going to bother you. But if you're 65, it will make a difference. We should treat you at 65. At 75, then we can have a negotiation about if we treat you or if we just delay it and see, you know, if it grows, then we'll treat you. If it doesn't grow, we'll just leave it. So there's a lot of room for negotiation. And then you've got the high risk group. And unfortunately, these men have a more aggressive tumour, or it might have spread outside the prostate by the time we diagnose it. In those men, we need to treat them soon. And there might be a group of treatments they have. So they might need some chemotherapy. They might need hormone treatment, because prostate cancer is a bit like breast cancer. So breast cancer is driven by female hormone. Prostate cancer, it's driven by male hormone. And we treat that with injections in order to dampen down the testosterone that your testicles make to stop the growth. And some men might need some radiotherapy. So I guess if we're talking numbers, in the population, 1 in 5 men will have prostate cancer. And of those 1 in 5 men, so this is all men up to the age of 100, and of those 1 in 5 men, probably about half of them, maybe just over half, will need treatment. So in the long run, lots of men will have it, but not all men are going to need treatment. So the monitoring, I just came back from a meeting, a European meeting, which was really interesting, because what they're trying to push now is that even for more of those men with that medium risk group, that we don't treat them until a lot later. And in Europe, that makes sense, because they've got so many patients. They're trying to save money and limit treatment as much as they can. And I think that's going to start happening more in Australia too. But as I mentioned, those low risk guys, we do what we call active surveillance. So that's a combination of MRI scans, blood tests, and maybe repeating the biopsy every 5 years or so. So it's not too much there. For men with the intermediate risk, so when we say, look, you need treatment, it doesn't have to be tomorrow, we've got time to think about it. For those men, we talk about a prostatectomy where we remove the prostate, or we talk about radiation therapy. And the choice of that depends on the man. It depends on his level of activity, his age, his health, his location, and you know, how we think he might cope with surgery. So how many men in the room would know someone who's had prostate cancer and maybe had surgery? Yeah, everyone, that's it. You've had prostate cancer?
3.5 weeks ago, I had a radical prostatectomy.
There we go. There we go.
I was Gleason 3-4.
Yep.
I was given a choice of a bit of active surveillance or radical prostatectomy. I'm 50 years of age. They were able to say it was right in the biopsy had located in both sides of my prostate, but it was nowhere near nerves or any of the rest of it. And I was given the choice of a bit of active surveillance or do something now and get rid of it. And I was just like, let's do it. So my urologist is Urological Solutions.
Oh yeah.
Dr. Alex J moved it, and Dr. Kim Paisley was my. This is not staged, by the way. Names, and you were like, I was like, Urological Solutions.
That's right.
So Kim Paisley was my urologist.
Yep.
And I'll tell you what, he's about the worst bloke, he's a glass half empty kind of bloke. He is shutting the door and he's walking to his seat and he tells you you've got cancer as he's walking to his seat like, there's no holds barred with that. But actually, like that about him, because I'll tell you what, he's as straight as a die.
Yeah.
Kim Paisley is actually my urologist. Dr. Alex J removed my prostate 3.5 weeks ago.
Yep. And you've catheters out?
My continence is 100% since day one.
Fantastic.
I wouldn't say my, let's say everything's improving down there. I'm on a few tablets and stuff, but it's going to get back here now.
It will. It will. Yep.
It's like sleeping on your arm and you wake up and it's like, oh, it's going to work. It's a process. You know what I mean? I knew it wasn't going to get right back there immediately. It's getting there.
It will, it will. And look, you're the perfect case study. That's it.
Yeah, so I know where you're coming from. I've been there 3.5 weeks ago. So.
That's it. And he lives to tell the tale. Look, that's fantastic, and that's best of luck with your recovery. I think you were right to take it out now because it had to come out at some point at your age. You know, absolutely. It was going to come out. You know, you're healthiest now than you are going to be in 5 years, and your chance of having cure and getting your erections back is much higher now than it would be later. So that's great.
I had somebody that I spoke to a while ago said to me, right. His brother and him had prostate cancer, and the two of them done two separate things. If you go for a full prostatectomy, you're at your lowest point and things only get better.
That's it.
If you go for that
radiation,
you know, radio beam, whatever, he was really good for 3, 4, 5 months, and then everything started to go downhill, and he didn't know what that was going to top. That's not to put anybody else off. I'm just saying to you, if you have a clear gap to everything else, you know, things are going to be different, but, you know, make that decision, just get it out of there, like, that's my opinion, I think.
Look, I agree with you. I think all surgeons would agree with you, but you've got to make the decision for yourself, and you've got to own that decision. You know, it's my decision, it's what I'm going to do. So, you know, we've talked a lot about surgery, and if you've got private health insurance, and even for most of our public patients now, you can have it done with the robot. That's overnight surgery. It's a catheter in for a week, maybe 2 weeks. It's a good operation, and it's only an operation that's been around since the 80s, so we've been perfecting it for the last 40 years. Radiation therapy, there's loads of different ways that they can deliver radiation therapy, and then hormone therapy is just for a select group of men. So just to recap, treating it early increases your chance of cure. Diagnosing it early increases your chance of cure. If it continues to grow, so let's say you leave it, it might spread outside the prostate, but the prostate can get bigger and it can cause you more trouble when you try to pee. So eventually it'll start causing you issues, which is why it's nice to just, you know, nip it in the bud. And when I started training, so when I met Kim Paisley in Clare and I started training with him, we would tell men 50% chance of living in 2 years if you've got prostate cancer in your bones and outside your body. That's blown out of the water now. There are so many treatments. We're seeing these men live 15, 20 years of good quality life. So it's very, very different. It's changed very quickly. So I've just got a few slides on incontinence, and then I'll leave you to your break. With incontinence in general, so it can occur after surgery or radiation therapy for prostate cancer, but it can occur in men who don't have prostate cancer because they might have a blockage in the tube that leads from the bladder to the outside world, the urethra, stricture we call it, or if the prostate's grown bigger and it's blocking the bladder and the bladder's not emptying very well, and you get what we call overflow incontinence, which could be a bit of a dribble. That then causes back pressure up to the kidneys. Kidneys go into failure and shut down, so you almost get worse side effects from that than you do from cancer. So I see a lot of men and women with incontinence issues. With men, it's more men who have had surgery and prostate cancer treatments. Otherwise, men with enlarged prostates, And so what we're looking is we're looking for any cause of blockage down that tube there. So whether it be the prostate, whether it be the narrowing there, whether there be stones sitting in the bladder, lots of different things can go on. And there are some very simple procedures and even tablets that can make your life a lot easier. What we do know is that if a man doesn't empty his bladder well, so this is your normal bunt or man without prostate cancer, if you're not emptying your bladder completely and you're leaving 200 ml, so like a cup's worth, behind in the bladder after you pee, 1 in 4 of those men are going to end up at the Boolaroo Centre looking for a catheter at some point in the near future, and especially if they've been on the booze one night. So these sorts of things just happen on a day-to-day basis. So if you're feeling that you're not emptying your bladder well, see your GP. They can organise an ultrasound scan. It's not urgent, but at some point you need to know, are you emptying your bladder well? Is your kidney function okay? Because those things can be fixed with some very simple procedures, if needs be. So if someone comes to see me with an issue emptying his bladder, he gets a cystoscopy. So where's Alice's scope? A bit like this. It goes up the front passage though. And most men don't have that with anaesthetic, I'm sorry, but it's a bit smaller. And then if you need, some men will get this treatment called urodynamics. So it's where I put a little catheter in the bladder and one in your bottom, and I measure your bladder pressures, and that just helps me work out if it's a bladder problem or a prostate problem. And then from there we sort of choose together what your best treatment is. Tablets is where we start for most men. Some men and women will need a bit of a bulking agent. So you think of lip fillers, you know, the Kim Kardashians of the world, all those people in the magazines. Instead of putting it there, we put it in the urethra. We put a sling sometimes in the urethra. And sometimes we have this little pump that we can put in as well. Again, that's really for men who've had prostate cancer where their incontinence might be bad. And that's me done. Thank you for your attention. Any questions? And thank you very much. What was your name?
Billy.
Billy. Thank you very much, Billy, for your input.
Just on the PSA test,
yeah.
How reliable are they? 100% reliable are they?
Look, they're pretty good, but there's lots of things that aren't prostate cancer that can cause the levels to go up. So we usually do 2. So before we decide to do an MRI or biopsies, you'll have them done 3 months apart. And if they're still up, so after whatever has happened to cause the first one to go up, we give it time to settle down. If it's still up, then you earn yourself the rest of the tests. But, you know, some men might have a PSA, so we test from about 3. Some men come to see us with a PSA 50, and that might be from infection. It's not even from cancer. So things that aren't cancer can cause much higher levels than cancer can. No worries. Any other questions? Stunned silence.
Is sex report or not?
Look, sex for the test is not great because it'll drive the levels up, but otherwise, it's absolutely fine. It won't increase or decrease your risk of cancer. Unfortunately, I don't have any tidbits, so I can't say that alcohol or anything other than being male increases your risk, so keep doing you.
Sophie, what about rectal examination? I don't know whether I saw it on your slide. Do we do those, do we recommend those for men anymore?
We really don't. So in the primary care settings, that's with your GPs, the guidelines have taken out the rectal exam because we find that the PSA, you know, more men are happy to have a blood test than they are to have a rectal exam. And if your rectal exam's normal but your blood test's high, you should still go see a specialist. And look, we were talking about it at this meeting, and as specialists, most of us, if we've got a guy who comes to see us with a high PSA, most of us don't examine you and check your prostate when we meet you because you're going to have a biopsy. We'll check it at the biopsy. We'll do an MRI scan. The men who we do test are the ones who come to see us who have trouble emptying their bladder, and their PSAs, the blood test, is kind of in the normal range or a low range, because you don't want to miss that small group of men who have a normal prostate but have prostate cancer. So they're the men that we will check the prostate if they have symptoms, but men who don't have symptoms and just have a blood test, you can avoid, I think in general you can avoid the finger test, and that's been out of the guidelines now for a couple of years. But you should have a blood test. They took it out of the guidelines for a few years, it was chaos, it's back in.
How much does genetics play a part in there?
It's important, absolutely. So if you've got a family history, we say to get tested from at least 45. So it's only the normal, so people without a family history test from 50. If you've got a family history from 45, and I'd say family history is, you know, anyone in your family maybe over 65 who's had it. I'd say anyone under 65, we'd start to think you were more in the high risk group. But they say, you know, you need 2 first degree relatives, all very complicated. So I'd stick to 45 or 50 and just go from there. Billy, any comments?
No, my father had it at 55.
Yeah, so you got...
My grandfather had it at 66. It was only whenever my dad had it at 55 that my grandmother told my dad that his dad had it 10 or 15 years earlier. They kept the secret. Yeah. So when my dad had it at 55, I was probably 28, 29. I've been getting my PSA done since I've been 40 years of age. It's been sitting about 0.9, 1.1. I'm a bike rider, you know what I mean? So I'm not really stopping riding bikes. So it's going up and down a little bit. For 48, it jumped to about 1.5, 48.5, 2, 49, about 2.5. This was Dr. Paisley's looking after me. 49.5 was, I think, was 2.9-ish or something. And he said, right, get it done in 3 months' time. Now, Dr. Paisley he's got big fingers, man.
He does.
Probably 4 to 5 times. I'll tell you what. I thank that man for it. He's looked after me really well, right? And he's had the MRI done on him. When I had my staging done, he's done extra. He's an absolute legend in neurology. But what I'm saying to you is right that as soon as it went 3.4, and I was 49 at that age, that was outside my range for being whatever 40 to 49. He was like boom, straight Flinders for a biopsy.
Yeah. And the first guy.
Tennyson Centre, it's a good spot to go if you've got issues like, or if there's a, and I'll tell you what, don't play them either. If your doctor says, you know what I mean, you know, blah, 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 you know, it's only this year, is there any, you know, maybe play it up a little bit. It can actually be a good thing.
Sometimes you need to push the point. Yeah.
So, absolutely. PSA, get it checked with your urologist.
The youngest guy I diagnosed last year was 46. With a PSA of 7, so his blood test was clearly abnormal, but you know his GP should never have done that blood test. We were just lucky. Yeah. Well, thank you so much for your attention, and we can have a chat later. Oh, thank you. Oh, I turned it off. Sorry.